Y para esta sesión inaugural contamos con dos invitadas internacionales. It's my great pleasure to introduce to this audience the two invited speakers for this opening session. The first speaker is Anastasia Pharris. She's an expert in HIV at the European Centers for Disease Prevention and Control in Stockholm, Sweden. Since 1997, she has worked on clinical and public health aspects of HIV in the US, Uganda, Zambia, Vietnam, Sweden, and now at European level. At ECDC, she is responsible for HIV surveillance within the countries of the European Union, an ECDC project on the HIV continuum of care and providing scientific guidance on the prevention of infections among injections, drug users, and men who have sex with men. Today, she's going to present an overview of the HIV situation in the European region and the challenges for the next decade. The second speaker is Paula Cannon at the Czech School of Medicine of the University of Southern California in Los Angeles, US. She's an expert in genome engineering in hematopoietic stem cells with an emphasis on developing new therapies for HIV. In 2010, her team was the first to show that genome engineering could be used to knock out the CCR5 gene in human hematopoietic stem cells, which has now led to an ongoing clinical trial in HIV-infected individuals. This evening, she is going to talk about the strategies of genome editing in curing HIV infection. Anastasia, Paula, thank you both very much for coming and hope you will have a great time with us here in Vigo. And please join me in welcoming Anastasia Pharris and Paula Cannon to this conference. Anastasia, please.
Thank you so much, and good afternoon to everyone. I want to start by thanking the HESIDA conference organizers for the nice welcome and for inviting me here. You have a vibrant and very high-quality network of researchers here in Spain, and I'd like to start by congratulating you. You're inspiring a lot of people, both within your own country and regions, but also throughout Europe and globally. So keep up the good work, and best of luck in your discussions in the next few days. I work at the European Centre for Disease Prevention and Control, which is in Stockholm, and we work with national health institutes in all of the countries in Europe. And today I'll be speaking to you about epidemiological challenges in our region. So a lot of your research, and in the next few days, you'll be looking very specifically into studies and p-values and different therapies. I'd like to zoom out for the next 20 minutes to look at the full region in Europe and to try to see where you are and where your work is with regard to the bigger challenges of the region. I have no disclosures. And so an overview of the epidemiological situation, what are the key issues? And then I'd like to move into how are we doing with prevention in our region in Europe, and what are the challenges that lie ahead in the coming decade. A lot of what I'm presenting is from the surveillance report, the HIV data for 2016, which my agency publishes together with the WHO Regional Office for Europe. And it was published today, so you're the first audience to see the new data and to hear some of the conclusions of the report. And you can download the report, and a lot of these slides, they're online already now. When we talk about the European region, we're talking about 53 countries, which span a very large geographical area and include over 500 million inhabitants. And often for epidemiological presentation, we divide the region up into west, center, and east, because there are some similar characteristics of the HIV epidemiology in those regions. And so in 2016, the most recent data available, we had more than 160,000 new diagnoses reported in this region. And of those diagnoses, about 80% of these occurred in the eastern part of the region, the majority of those in Russia. Far fewer were in the central part of the region, 4%, and 17% were in the western part of the region, where Spain is also located. If we look at what does this mean and what is the variety across Europe with regard to the notification rate, we can see there's a lot of diversity. And again, with an 18.2 diagnoses per 100,000 in our full region. But if we divide this by sub-region, we see a big discrepancy with quite low notification rates in the central part of Europe of 2.9 and very high ones in the eastern part of the region, over 50 per 100,000. And so how does our region, if we zoom out even further to the global picture, we've seen a lot of good news recently, and a lot of this is the result of investigations and research that people like you are doing. So globally, HIV infections are decreasing, and this has been wonderful news. We've seen this predominantly in sub-Saharan Africa, but elsewhere as well. However, in our region, we see the opposite, and in fact, the WHO European region is the only region where we see an increase in infections. And this is largely due to the increase in the East, where we've seen a big increase in the number of new cases diagnosed and infected. West and Center have kind of a flatter line at the bottom and a less dramatic picture. And so if we dig into the reasons for this, we can see that in the eastern part of the region, so maybe contrary to what one might think, I think often we connect the eastern part of Europe with a lot of injecting drug use related HIV transmission, and that was the case at the beginning of the epidemic, and there are still many infections due to injecting drug use in the east. But we also have seen a big increase in heterosexual transmission in that part of the region. And this is partly due to partners of injecting drug users, and may also be some underreporting of other routes of transmission due to stigma. We see very low at the bottom. There's been a very low numbers of cases reported due to sex between men in the eastern part of the region, but this has increased a lot over the past decade. In the central part of our region, we have much lower numbers, as I showed you at the beginning, but quite proportionally large increases in cases due to sex between men and heterosexual transmission. And we also saw an outbreak in this region in Romania during sort of the middle of the last decade due to injecting drug use. And then in the West, we have seen, this is the region where we've seen a decline in new infections due to heterosexual transmission and also due to injecting drug use. And over the past decade, we'd seen an increase in infections due to sex between men, and only this year have we started to see a decline in this population. And this is mostly due to declines in a handful of countries in the EU, but not overall. In many countries, there still are increases in this population. This is some data just to show that there's a diversity. So when we talk about Western Europe or Central Europe, we can't, things look very different if you compare countries. And so the proportion of infections in many countries, the blue part of the pie, is due to sex between men, and green is due to heterosexual transmission. But we see that this looks quite different, and so what the epidemic may look like in Spain may be quite different in a neighboring country of France or Luxembourg. Part of the decline that I mentioned earlier in sex between men, we've sort of started to note, and if we look by age groups, it's quite interesting that we see this decrease from 2015 to 2016. It's very slight, but it's only in the younger age groups, and we haven't seen a decline in men overall in the 40 and 50-year-old age groups. The same trend in women. We've seen a big decline in HIV infections among women in most of the age groups in the past decade, and this is largely due to less infections reported among women who are from sub-Saharan Africa and other countries with more HIV than what we see in Europe, so migrants within Europe. But this has started to level off in the most recent years, and again, the declines we have seen are more or less kept to the age group of 20 to 39-year-olds, and no decline among women over 40. I'd like to stop a bit on migrants because this is an important population for epidemiology for HIV in Europe, particularly in many countries in Western Europe. And so over the past decade, we have seen that about 40% of new diagnoses are among people who are born outside of the country in which they're diagnosed. And those of you working clinically see this in your clinics, and this is your patient population. But here in 2016, the most recent data, we see that about 40% of new diagnoses are in this group. And if you look at the colors, these are not all people from sub-Saharan Africa, but quite a variety of places, including a lot of other persons who were born in other Western or Central European countries. And this is a challenge moving forward as we try to adapt our clinical care and also research and testing modalities to more diverse populations. Some important research has been done, led by some researchers here in Spain, including Julio del Amo and Deborah, who have been part of the AMAZE project. And one of the questions often when we present data on new diagnoses in Europe among migrants, people say, yes, but they were infected, in their home country. We need to diagnose them and offer them treatment, but it's not an issue of prevention. And in fact, the AMAZE study did very important work to look at where is the infection actually happening. And they did a long questionnaire and applied multiple methods and concluded that in the 9 European countries where they did this research, that about 63% of those HIV-positive migrants had been infected after they migrated to the European country in which they were diagnosed. This was even higher in MSM, 72%, and was higher for Latin American and Caribbean migrants. Similar research has been done using a CD4 back calculation method in the United Kingdom, and they have found that when they apply a CD4 more objective method to understanding whether the person has been infected before or after arrival, that 46% of migrants, this was in 2010, they've seen further increases in more recent years, have been infected after arrival to the UK. And so why is this important? It's important because it's not enough only to offer testing, but we actually need to think about the risk profile of migrant populations when they're in Europe, and also think about how to develop and deliver non-stigmatizing prevention services to very diverse populations across Europe. So moving on a bit to the response. The policies and the prevention that we are applying here in Europe, is it enough? I wanted to reflect a bit on the Sustainable Development Goals, and all of the countries globally have signed up to these goals, and UNAIDS has developed, in line with the Sustainable Development Goals, these fast-track commitments. So for our region, for the wider European region and Central Asia, one of the goals is to reduce the new infections to fewer than 63,000 by 2020. Now, you remember I said we had 160,000 new diagnoses in 2016. To reduce AIDS-related death and to eliminate HIV-related stigma are the other two goals. And so will we make it? This is the graph, so the solid line is the region and what we see in terms of new diagnoses. This is not incidence, but new diagnoses. And the dotted line is where we would need to get to by 2020 in order to meet this target. So as you can see visually, we're quite far off from reaching that in the wider region. The blue line represents the EU, and we also have a goal for the sub-region of the EU, and that would mean reducing the new infections by 1/3. And while we have started to see a decline in kind of the more recent year or two in the EU, we would still need to reduce the infections quite a lot. So the 1990 targets have been mentioned already in the opening, and there's been a lot of focus on these. The targets of 90% of people living with HIV being diagnosed, 90% of those diagnosed on antiretroviral treatment, and 90% of those virally suppressed. So this means a cumulative of 73% of people living with HIV would be virally suppressed. And we have done a policy survey across countries in terms of where they are with regard to the 1990. And this is the first target, which is 90% of people living with HIV diagnosed. We see a quite diverse picture among countries in Europe that have data, many still do not, but definitely a very large west to east gradient with regard to the proportion who remain undiagnosed. And so while the target is 90%, we see that the west and center are nearly reaching that target, but the east is quite far away. And a lot of this is because of another item that's been mentioned already is late diagnosis. So we see that in 2016, 48% of new diagnoses in the EU were diagnosed with a CD4 count of less than 350. If we look at the wider region, that's 51% of new diagnoses. So still, we have very effective treatment, we have good testing, but we're not reaching enough people early enough to make enough of an impact. And this is the proportion diagnosed at CD4 counts of less than 350 divided by region. And I think it's interesting to look at, while in the blue line, the center, we see a reduction in late diagnosis. In the West, we see sort of a stable situation. In the East, we actually see an increase in the proportion of infections that are diagnosed late. And this is concerning because that's the region where we've seen a lot of new infections and diagnoses are reported. We did some modeling work on the same issue, which will be published this Thursday in Eurosurveillance, and we looked at EU countries and tried to estimate the time from infection to diagnosis using CD4 back calculation. And what we found is that in all parts of the EU, we divided into these four sort of sub-regions for this analysis. We see that we are diagnosing people earlier over time. So the median time from infection to diagnosis is becoming less. And that's good news, but it still is 2.9 years on average, or the median across the European Union. And the red line, the south, has even higher estimated median time from infection to diagnosis. So there's definitely room for improvement throughout the EU countries. Looking at the second target, the proportion of people who are diagnosed who are on antiretroviral treatment, we found, again, a really, really strong west to east gradient, where upwards of 90% or 80% of those in many Western countries who have been diagnosed are on ART, and much lower numbers in Eastern countries. These are sort of the sub-regional targets. 45% of those diagnosed are on treatment in East. And when we look at the policies, we've seen a really big change in recent years, and this is extremely important. In 2014, when we asked countries, when are you initiating treatment? What is your national policy? We found that many countries had a policy of 350. Some initiated at 500, and a few were initiating regardless of CD4 count, so test and treat. We saw EACS put out new guidelines in 2015. Of course, they've been updated since, but in 2015, they recommended initiation of ART regardless of CD4 count, as did WHO. And we've seen a really big shift now in country policies, so that the majority are implementing test and treat policies, and others are thinking about doing so, although we still have a handful of countries that are treating at 350. I want to mention, while we're talking about treatment, this issue, which is very, very important, that regardless of the policy in many countries, still in a lot of countries in Europe, even if it is the policy to provide treatment at testing, there are still some populations that are left out of this policy, including undocumented migrants in many countries in Europe. So even if they're tested positive, they don't actually have access to treatment. And this, of course, doesn't make sense with regard to public health policy and infectious disease transmission. And kind of looking at the last target now, the proportion of all people living with HIV who are virally suppressed. Here we have a lot of data gaps, so the countries in gray don't have all of the points in order to estimate this. But the countries that can do it have seen a very sort of good picture in many of the Western countries, and quite dismal picture in a lot of the countries in the East. So the EU as a whole has about 65% of those who are estimated to be living with HIV who are virally suppressed. And outside of the EU, non-EU countries, it's about 24%. So a very, very big difference there. And we also know from modeling work that's been done that this 73% target is a political target, and it wasn't the result of very thoughtful estimates of what would actually have an impact on the epidemic. And when Andrew Phillips and colleagues have looked at this more carefully in the United Kingdom context, they found that upwards of 90% of viral suppression amongst all people living with HIV would be needed to have an impact on incidence in their context, particularly among MSM. And so even where we see green and feel happy that the map looks good for our country, it may not actually be enough to impact incidence. So turning and finally towards the challenges and opportunities in the next decade, I think we're in interesting times now because we have a lot of tools, and the challenge now has become implementing what we know works, actually doing it at scale. One example of this, and something that is it has a long history of experience here in Spain, is harm reduction. So we know this works well, but many countries in Europe, and I'm sorry if you can't see this slide very well, but still have very, very low coverage of opiate substitution treatment, which is extremely effective in preventing HIV and hepatitis in people who inject drugs. Many countries still have very low proportions of those people on drug treatment. And needle and syringe programs on the right-hand side, there's still very, very low coverage of many of those programs, which we know are effective in preventing HIV and hepatitis. Another thing that we know works is more frequent testing and rapid linkage to treatment. And this is easy to say, but sometimes harder to implement. We've seen really exciting data from London clinics, which has been presented at various conferences this autumn, where they've looked at clinics where they've seen very large decreases in London, and this has accounted for a very large national decrease, actually, in their setting. And what they have seen is a commonality in the clinics with large decreases in new infections, is that they have implemented very rigorous testing policies where they're changing the culture of testing among predominantly gay men in that setting, who are coming more often to test. So it's not a question of, have you ever tested for HIV? It's, when did you last test? And getting men to become used to testing every 3 months or every 6 months according to risk. And they have also changed so that when people are found to be positive, they're immediately linked to treatment and started on treatment, often within 7 days. PrEP has also been implemented in that setting. They don't believe that that has been the main reason for this decline yet in their setting, but it has been a contributing factor. And so looking at testing, how do we get testing to more people more often and earlier? And there are different policies across Europe. So community-based testing is something that is not implemented in every setting. This is community testing by medical staff. And so yellow means limited, green is moderate or extensive, and red means none at all. Many countries also implement testing in the community by peers or others who are not doctors or nurses. And this is quite common in some settings and has been quite successful. But it is actually not under the legal framework of many countries in Europe. And this is not implemented in the settings that are colored in red. Home sampling is something that's quite new and that has been piloted in just a few countries in Europe and has been quite successful on a small scale there. And this may have a role in getting some groups who do not come into other types of clinic settings to test. Another challenge is harnessing new technologies. So we have an amazing amount of tools at our fingertips on our mobile phones. And so how do we use these to be smarter about the prevention that we're doing? Something that we've done together with NAM, AIDS-MAP, and HIV in Europe, and the Terence Higgins Trust is we tried to get the message out about European HIV Testing Week using mobile telephones. European Testing Week just finished last week, as you may know. And so what we did is create a European HIV test finder together with NAM. So they have looked extensively for the lists of places that are doing testing across Europe. And then you can look for it and get a map, or else you can get a list of clinics based on where you are. It's geolocated. And we partnered with some gay dating apps, in this case, Grindr, Hornet, and Planet Romeo, and asked them, we have this list of testing sites in Europe. Could you perhaps help us to promote this? And they were happy to do this. They first said, though, you need to make sure this works, so it looks nice when you open it on a mobile phone, because that's the way that our apps work. And we worked together to do that. And then they sent push messages to all of their users during HIV Testing Week in different ways. And the user could then put in the country, put in the town, the postcode, and get the results in a map for the nearest testing site. They sent to users in 55 countries in 40 different languages. They provided the translation for free. and banner ads to others. And we found that this was comparison between 2014 and 2015, but we found that it increased the number of visits and page views to the site that we've had significantly. And so getting more people to get the information that they need and sending reminders through the apps that they're using to network and to meet was found to be very effective and is something we could do much more of going forward. PrEP is something that we discuss in every HIV conference now, and this is the most recent policy map that we have of PrEP implementation across Europe. So dark green are countries that are implementing PrEP through a national program, through the national health system, or who have sort of wide PrEP access to all. Lighter green are countries that have ongoing demonstration projects or planned demonstration projects. And red are countries that have no ongoing activities. This is changing by the week, by the month, and so every time that I present it, someone comes up to me and says, actually in my country now we have this project. And so this may be the case here as well. But this map looked very different 3 months ago and 6 months ago when we first did the policy questionnaire to countries. And this is an area where we see a lot of movement, a lot of discussion across Europe. What we do know, though, is that despite what the formal programs say, and despite the lack of very many formal programs in many European countries yet, we believe there's a lot of informal use that is going on. And so together with one of the gay dating apps called Hornet, we did a small survey. They pushed out the survey that we wrote for free to users in the European region. And we got about 11,000 respondents, and found that of those who responded who were not HIV positive, about 10% said that they were currently taking PrEP. And this was based on very different sample sizes across Europe from different countries. I think we had about 200 respondents from Spain, and about 7% said they were currently taking PrEP. When we ask, this is the results for all respondents, where did you obtain PrEP? Those who responded, we find that about half said that they were obtaining PrEP through a physician or a research study, and nearly half said they were obtaining PrEP from the internet, from a friend, or taking post-exposure prophylaxis as pre-exposure prophylaxis. So this resulted in about 47% informal use of PrEP. Again, this is across all countries, and it may look different in your setting. But this is really important because as we try to decide what to do with formal programs, many people are nonetheless implementing and using, perhaps correctly, perhaps not correctly, and there are risks with regard to toxicity, of course, with unmonitored PrEP use. Nonetheless, we believe that PrEP is an effective intervention and would be part of a toolkit of interventions that should be applied, especially to prevent HIV among men who have sex with men. And when we look at how many European countries are really delivering a very comprehensive package of interventions for MSM, this is what we know works to provide condoms, health promotion, sexually transmitted infection testing, as well as PEP and PrEP services. We find that quite few countries, it was only 2 in 2016, who had all of these in place. And so there's a lot of room for just implementing the package of services that we know works for the population that's most affected in our region. And this is a challenge going forward to try to look at reviewing programs and trying to understand, is the scale good enough? And often, we have a lot of good ideas at European level about what should be done, but we understand and realize that funding is a big issue. And 2 out of 3 countries in Europe have said that they don't have sufficient funds in order to carry out the type of prevention they think would be necessary to impact the epidemic. And so this is quite important, that in order to apply these effective interventions, sufficient funding would be needed. And I'd like to end by just mentioning stigma. This is one of these issues that we often talk about, but it does impact the likelihood that someone will come to test, the likelihood that they will be linked to care and will follow up and be adherent to HIV treatment. And this is data from the European Fundamental Rights Agency, which did a survey, an internet survey of gay men. And they found that there was a very big difference in the proportion of gay men who reported that any healthcare provider had ever been aware of their sexual orientation. And we find, again, a very big gradient of west to east here, where in many countries in Europe, more than 50% of gay men have never disclosed their sexual orientation to any healthcare provider. So this has implications, of course, for HIV testing offer, for PrEP access, and sexual behavior counseling. And I want to end with just a few other factors, which I don't have time to get into here, but which are affecting the way that we deliver HIV prevention and care, and will continue to do so in the decade ahead. In many settings, there's increased political instability. In some settings, austerity measures, which are strongly affecting the way that health systems are organized and delivered, and public health funding is allocated. Some systems are, as a result of these things, seeing some restructuring that's affecting the way that especially sexually transmitted infection care is provided. Migration continues to affect the way that HIV care is delivered and the risk populations that we care for. An aging cohort of people living with HIV, I think there's quite a lot of discussion at this conference about this topic. And then also changes in the illicit drug market. And so things like new stimulants coming onto the market, which we've seen outbreaks as a result of this in Romania, recently in Scotland, we've seen this in Ireland, and now more recently in Luxembourg, where the drug use patterns change and HIV infections result as a result of the changing drug patterns. And so in conclusion, as a region, Europe is lagging behind in its response. We're not on track to reach the 2020 targets that we have signed up to. This does not mean that this is the case throughout the region. It's predominantly in the East, but we need more effective ways to sort of cross-fertilize the evidence of what works in countries where things are going well to the neighboring countries where things are not going as well. We know what works. We have a lot of effective interventions, more than ever before, and we know that frequent testing is useful. We know that linkage to care and antiretroviral treatment initiation immediately after testing is very, very effective. PrEP is extremely effective, but we don't see these being applied very quickly across Europe. The uptake has been quite slow. But we do have good news. The epidemiological data has shown that we do have some reduced incidence, new notifications in MSM in some countries in recent years. We've seen a decrease in heterosexual infections in many countries in the EU. Overall, throughout the region, we've seen a reduction in mother-to-child transmission and also injecting drug use-related transmission of HIV. So these are success stories where Europe has started to lead the way, and we have the tools that are needed in order to continue to reduce HIV transmission in other populations. I'd like to end by thanking my colleague Tamer Nouri from ECDC and also my WHO colleague Anne-Marie Stengard, who collaborates on HIV surveillance. We have a lot of people in the countries throughout Europe who supply the data, the surveillance data, and the Dublin response monitoring data. And so I'd like to acknowledge them and to thank them for the excellent work that they're doing at country level. And I'd like to wish you good luck in the rest of the conference going forward, and I hope that some of these European data can provide a little bit of perspective with regard to the important work that you're doing and how this fits into the challenges throughout the region.